everyone to this session on 30 minutes, 30 images. So my name is Dr. Jhanvi and we are going to be starting with this new TMTI series. Okay. So what do you mean by TMTI series? TMTI series is nothing but in 30 minutes, 30 images. Okay. So in 30 minutes, we'll be doing 30 images. Now I'm starting off with my subject anesthesia. But here forward, we are also going to be doing TMTI series in all the subjects. So we're going to be doing surgery, PSM, patho, you name it. Okay. So every day at the same time. I know today it's like a little 15 minutes late because I was not sure whether I'll be back from work at the right time or not. So every day at 8 p.m. we will be having this TMTI 30 minutes, 30 images series. Okay. So this will be there till the end of this month. It's not an MCQ session, but we are going to be having only the images and you have to identify. So image, identify, like that. Okay. So it's going to be a quick series and we are going to include lots of images. So we are not going to waste any time. All right. So without further ado, let's begin our class for today. Welcome to Plus subscription on Unacademy. You will get daily live classes, live tests and quizzes, structured courses and unlimited access using a single subscription. The iconic subscription will give you the best of Unacademy in the form of live classes and batch courses, along with the best of Prep Ladder in the form of video lectures and question bank. This is the NEET PG test and analysis batch, which has already started. You can see it is a 2-month batch. Subject-wise, we are going to be covering each and every subject, all the important topics that are asked in every subject. And also we have a grand test series schedule along with this batch. So you can see there are 12 grand tests that are scheduled, out of which 2 are already done. Now we also have a ultra fast track high yield revision batch, and this is the 2-month subscription, especially for NEET PG students at 6750 rupees only, with which you will be able to access these batches. And we also have the 12-month subscription with which you'll get 2 months free. We have the Target Next 2022 batch, Professional Year 4 batch, Focus FMG batch for December FMG students. And this is the end of the iconic subscription now. It is going to end in the next 10 days. So if you want to buy the iconic subscription, last 10 days to avail of this special price. We also have the 4-year subscription. Now, whatever subscription you buy, there are many of them available. You can use my code Dr.Jhanvi Live and you can get 10% off on your Plus subscription. So let's begin with our class for today. This is the first image for today. Now, can anyone identify what is happening in this case? If they give you this image and they ask you identify, what is this? Very good. It is Bier's block. Can anyone tell me what is the other name for Bier's block? Other name for Bier's block, guys? Very good, Gunjita. It is also called as IV regional anesthesia. Okay. So what do we do in Bier's block? In Bier's block, we attach a tourniquet and we inflate it. So this is the question that they ask in the exam. What is the inflation pressure of tourniquet? If you are going to do Bier's block in the upper limb and if you are going to do Bier's block in the lower limb, then what is the inflation pressure of Bier's block of this tourniquet? Can anyone tell me? Okay, all right. So remember, whatever is the systolic blood pressure, okay, whatever is the systolic blood pressure plus 100 mmHg in the upper limb, and whatever is the systolic blood pressure plus 200 mmHg in the lower limb, that is your tourniquet pressure for IVRA. Okay, so what do you mean by this? So if I tell you that the patient's systolic blood pressure is 180, okay. So how much will your upper limb tourniquet pressure be? If you are going to put the tourniquet in upper limb, it will be 280, okay. And your lower limb tourniquet pressure, it will be how much? 380, okay. So that is how you calculate your tourniquet pressure. Next question that they ask about IVRA. If the patient has methemoglobinemia, which are the 2 local anesthetics you will avoid in IVRA? Can anyone tell me what are the 2 local anesthetics to be avoided if the patient has methemoglobinemia? Very good. One is prilocaine and the second one is benzocaine. Okay. And last one, what is the contraindication to IVRA? Give me a couple of contraindications to IVRA. One of the pathological diseases in which you will not do IVRA. Yes, very good. So in sickle cell anemia, okay, in sickle cell anemia, we will not do IVRA, and in PVD. Okay, that is your peripheral vascular disease. We will not do IVRA. Okay, is that clear? All right. So this is all about our IVRA. You should know about this. It is also called as Bier's block or IV regional anesthesia. Now, a lot of you have joined in a little late. So I just wanted to tell you that we are going to be doing this series. We are going to call it as the TMTI series. Okay, TMTI, 30 minutes, 30-minute series every day at 8 o'clock. Today it's at 8:15 because I got a little late in scheduling the class. But we are going to have this every day at 8 o'clock. We are going to be covering images from forensic medicine, from surgery, from pathology, from all the subjects possible. Okay, so half an hour, high yield images of all the subjects. All right, now let's move on to our next image. Can anyone identify what is this? What is the mode of anesthesia in this case? So that is how your question will come. What is the mode of anesthesia in this case? I don't want to know which part of block it is. Just tell me the mode of anesthesia. Is this general anesthesia? Is it regional anesthesia? Is it caudal anesthesia? What is it? Yes. So this is your regional anesthesia. In which region is it targeting on? Can you tell me the region it is targeting? Yes, so this is your brachial plexus block. Okay, now your brachial plexus block, if you see, there are many approaches to it. So when it's so high up in the neck, you can see this is a USG guided brachial plexus block. So when it's so high up in the neck, this is your interscalene block. Okay, if it is little lower down over here, that will become your supraclavicular, just above the clavicle. That will be your supraclavicular. Okay. And there will be another one just below the clavicle. Suppose this is the clavicle, below the clavicle is infraclavicular approach. And if you go in the axilla, then you have axillary approach. Okay, so these are 4 approaches for brachial plexus block. Now they are not going to ask you in your exam, is this interscalene, supraclavicular, infraclavicular or axillary? Okay, the highest approach is interscalene only, high up in the neck. You don't have to know that, you just have to know this is a brachial plexus block. Now, why I'm showing you this is many of you will mark the answer as central venous cannulation. Okay, so you all, because USG say when you put a central line also, similar SI, it looks like that. But I don't want you guys to make that mistake in the exam. Look at the sono anatomy, look at the image. They will mark the anterior scalene muscle and they will mark over here the middle scalene muscle. Okay, middle scalene muscle. And if you see over here slightly, there will be a needle going in. And there are 3 holes like this, hypoechoic holes. Okay, so this makes the traffic signal sign. So you will be able to identify that this is your nerve block. Okay, do not get confused between nerve block and IJV insertion. All right, so this is your nerve block. What is another way of identifying it? See over here, your IJV and your carotid will be somewhere closer to the midline. It will be over here. Your IJV line will be closer to the trachea in the midline. Okay, so it would be somewhere over here. On the other hand, you can see this needle, where is it going? It's going behind. Okay, so this needle is going into the brachial plexus. All right, so this is how you identify the block. All right, now can anyone identify these 2 things that we use? This one is a difficult one. I don't have the image of IJV now, but if you guys want, I will put it on my Telegram group. This is my Telegram ID, ACE NEET PG with Dr. Jhanvii. So anyone who's not there in the Telegram group, you can come here. I will put the image of the IJV. Okay, so what is the name of this instrument that we use? It's not ICP manometer, but you're close. It is some kind of manometer, correct? It's checking the pressures. Can you tell me what pressure is it checking? See over here, if you see, it says 10 mmHg. And if you see this one also closely over here, this is showing you 15 to 20 and 25 mmHg. So no, can you see it is connected to a syringe? So this is nothing but an injection pressure manometer. Okay, this is injection pressure manometer. Now, do you know what is an injection pressure manometer? Any idea? Okay, so we use this in regional anesthesia only. Injection pressure manometer basically means it will check how much pressure your syringe is requiring to push the drug inside. Okay, so we use this in regional anesthesia when I'm giving a block over here. Suppose I'm giving a brachial plexus block. In that case, what happens is sometimes my needle can enter into the nerve. If it enters into the nerve will permanently get damaged because I'm causing trauma to the nerve. Okay, so this injection pressure manometer, if it is showing a pressure of more than 15 psi, that means I am inside the nerve. Okay, so I'm going to damage the nerve. So I will never give the injection at such a high pressure. I will make sure that my pressure when I'm injecting the drug is less than 15 psi, so that I know that I am not inside the nerve. Okay, so how will you identify it? This is an injection which is connected directly into an injection pressure manometer. Okay, all right, next one. On similar lines, this is another thing that we use in anesthesia. You all must have heard of this also many times. No, okay, I want to know what is this. Sorry. Many of you all are answering this, but you're correct, Shubhra. This is a laryngeal tube. This works both like an LMA as well as like a endotracheal tube. But I want to know what is this image. See what it is doing. It is connected to the pilot balloon and cuff inflation line, and it is basically doing something about these cuffs. Very good, Dr. Grace. So this is called as cuff pressure manometer. Okay, another thing that checks the pressures. So have you all heard of cuff pressure manometer? Where have you all heard of cuff pressure manometer? Yes, it checks the pressure of this cuff. 100% if you all have attended my ACLS class, I have mentioned about cuff pressure manometer. Okay, so what happens is that if this is your trachea and this is the tube that you're putting in, okay, and you inflate the cuff. Now, if you overinflate the cuff, the cuff puts a lot of pressure here on the bronchial vessels, and it causes the flattening or the compression of the bronchial vessels, which can cause ischemia. So that is why they always say you should check the pressure of the cuff, and this is especially true in children. So in ACLS guidelines, it says that nowadays we don't prefer uncuffed tubes in children. We prefer cuff tubes only. And when you use a cuff tube, you should check the pressure in the cuff. So how much should be the pressure in the cuff when you check it through the cuff tube? Any idea? How much should the pressure in the cuff be? Okay, so it should be less than 20 mm of Hg. Okay, so this is ACLS guideline, guys. Please remember this. This has come from ACLS. Okay, so your cuff, endotracheal tube cuff pressure should be less than 20 mm of Hg. Okay, all right. Next one. Identify between 1 and 2, which is spinal needle and which is lumbar puncture needle. Which is spinal needle, which is lumbar puncture needle. Dr. Baby, they say that you should not use uncuffed tubes anymore because they can have the risk of aspiration. Okay. All right. So little bit you all need to know about this. Now, whenever you have a thicker needle, bigger needle, you remember your lumbar puncture needles are basically used for fast drainage of CSF. Okay. So you need a big Motasa needle for that. So big Motasa needle is this black needle. It is 22 gauge. Okay. And when you have smaller needles like the blue one, agar yahan pe blue color ka hub ho, okay, blue one, that is 23 gauge, and this one, orange one, this is 25 gauge. This is your spinal needle. Okay, in spinal needle you don't need a very thick needle. Why? You need a thin needle. You just want to give the drug through it. You don't want to collect CSF outside. But in your lumbar puncture needle, you want to collect CSF. You want it to flow as much as possible so that the ICP of the patient reduces. Okay. Is that clear, guys? So we have a spinal needle over here, 1, and 2 is your lumbar puncture needle. And what is number 3 over here that I have shown? Yes, very good. So number 3 over here is your epidural needle, also called as 2E's needle. Okay, 2E's needle. And how do we identify epidural needle or 2E's needle? We can see over here there is a flange. Okay, flange or wings are present over here, and you have alternate light and dark markings in this case. Okay. So this is how you will identify the different needles. Okay. Now, fatafat se tell me, I have given you as per the colors. So yellow color is how much gauge? Yellow color IV line. Any significance for those markings? Yes, Dr. Manisha, these markings will basically tell you how deep is your epidural space. Okay, this is a 3 centimeter marking, and then it's 1 centimeter in. So it will tell you how deep is your epidural space from the back. Okay. So what is our size of this? Yes. Okay, so Navjats has given it quickly, so we save time over here. So we have 24 gauge. Now we have another purple needle that comes over here, purple IV cannula. So purple one is 26 gauge. This one is 22 gauge, blue one. Okay, then pink is 20 gauge, green is 18 gauge. Then we have gray, which is 16 gauge, and the biggest one, that is orange, which is 14 gauge. Okay, so everyone knows IV cannulas now. Okay, what is the difference between IV cannula and angiocath? Can anyone tell me the difference between IV cannula and angiocath? IV cannula and angiocath. Okay, so if you have this port over here, you open this port and you give injection through it. Okay, yes, so your angiocath will have the port. Okay, so you can give injections directly from there. Okay, so the next question, different types of tubes. Before that, I want to ask you, what is this tube that you can see over here, and what is the difference between the tube? Very good, it is tracheostomy tube. Can you tell me which one is picture 1 and which one is picture 2, and what is the difference between them? What is, yes, one is metallic, but what is the name? It is Chevalier-Jackson tube, correct? It is Chevalier-Jackson tracheostomy tube. And what is this part called as? This they will ask you in the exam. What is the special thing that helps in guiding the tracheostomy tube inside called as? Yes, it is called as a obturator. Okay. And what is 2? 2 is also a tracheostomy tube, I agree. It is called as Portex tracheostomy tube. Okay. Portex is the name of the company. It is a Portex tracheostomy tube. Now, what are the differences between 1 and 2? What are the differences between 1 and 2? Yes. First difference is cuff. Second and most important difference is that number 2 is disposable. Okay, so you don't reuse it between patients. You use it only once. Okay, yes, absolutely correct. Okay, now coming to the tubes. Identify tube number 1, tube number 2, tube number 3, tube number 4, and tube number 5. Quickly. I want you all to write in the answer in the chat box. 1 is this, 2 is this, 3 is this. Yes, very good. 1 is flexometallic tube. It is also called as armor tube. Okay, what is 2? 2 is normal endotracheal tube, cuff tube. Absolutely correct. What is 3? Yes, 3 is uncuffed endotracheal tube. So you can see in 3 there is no cuff over here. There is nothing present. What is 4? Yes, so 4 and 5 both are your RAE tubes or ring Adair Elvin tubes. Okay, so 4, as you can see over here, is a south pole tube. Both of them, both ends are facing in the same direction. And 5, if you see over here, it is a north pole tube. Okay, both ends are at right angle to each other, right angle. So this is your north pole tube. Okay, all right. Again, what is 1 and what is 2? What is 1 and what is 2? Yes, absolutely correct. So 1 is armored tube and or flexometallic tube. Both of them are same pictures. Okay, and what is 2? What is 2? Not chest tube. It is called as a double lumen tube. And for what kind of surgeries do we use this double lumen tube? It is used for, everything is double. 2 cuffs, 2 balloons to inflate the cuff, and 2 ends. Okay, double lumen tube. It is used for thoracic surgery when you want to give one lung ventilation. One lung ventilation. All right. Okay. Next, identify. Identify 1, identify 2, and what is the main difference between them? Guys, when you write AED, I want to know the full form of AED. I don't want just AED. Exam may they will give you full form of AED and they will give you different words and you will get confused at that time. Difference between flexometallic and normal cuff tube. You can see in flexometallic, you can see these rings are present inside. This is not present in normal cuff tubes. That is why it is called as flexometallic. It has these metallic rings inside, which makes it very flexible to use. Okay. All right. So this number 2 is automated external defibrillator. Okay. Okay. Automated external defibrillator or AED. So you must have seen this in movie theaters, at airports. This one is seen. And what is 1? What is one then? Is one also AED? One is not AED. What is one? Very good, Shubhra. So one is a manual defibrillator. Okay, and this you must have seen in Hindi movies. What will they do? They will pick up these paddles over here and they will shock the patient. This is जोर का झटका धीरे से लगे, है ना? That shock. Okay, so this is the manual defibrillator and this is an automatic defibrillator. What is the difference between manual and automatic defibrillator, other than the fact that in one you have to give shock with the paddles and in the second the shock will get delivered automatically? What is the main difference between manual and automated external defibrillator? Yes, in manual, basically you will set the voltage, how many joules of energy you want to give. And the second thing is you have to identify the rhythm. You have to identify the rhythm, okay, whether it is shockable or non-shockable. In AED, you don't have to use your brains at all. You just have to connect the pads, and these are like sticky pads. You can see over here, they have given you also on that how and where the pads need to be attached. So this can be used even by a layman. So once the pads are attached, automatically it will analyze the rhythm. If it is shockable, it will give the shock. If it is non-shockable, it will not give the shock. Okay. So everything in AED is automatic and everything in manual defibrillator you have to decide. Okay. All right. Next one. This is the anesthesia machine. Now I want you guys to identify only one thing. What is one? Flow meter. Very good. So it will show you the flows of fresh gases. What is two? One will say, ma'am, एक चीज पूछिए और फिर सब कुछ पूछ ले. What is two? Yes, two is vaporizer. It contains all your inhaled anesthetic gases. Now, what are all these dials over here? These dials that you can see over here. What are they showing you? Any idea what these dials are showing you? Pressures. Very good, Akhand. So these are basically showing you the pressures. Which pressures? They are showing you the pressures in the cylinders and they are showing you the pressures in the pipelines. Okay. All right. Now, can you tell me what is 3 over here? ऐसे jumping jack जैसा चीज आता है इसमें. Jack in the box जैसा चीज. No, it's not. It's not soda lime over here, guys. Soda lime will come here down. Okay. Soda lime cannula canister will come here. This is your CO2 absorber. Here you will have something like jack in the box. ऐसे ऊपर नीचे जाता है ना jack in the box जैसे. Bobbin. Okay, they are called as bellows. Bellows. Okay, they will push the air under pressure, under positive pressure. Okay, all right. And then what is this button? The green button over here. Yes, this is your emergency oxygen flush button. So whenever your patient is desaturating, immediately you'll press this oxygen flush button and you'll give high flows of 100% oxygen to the patient. Okay, so these are the basic parts of the anesthesia machine. And what is this number 5 over here? This is nothing but a screen which shows the ventilator graphics. Okay, all right. Next, Boyle's apparatus. No, this is not Boyle's apparatus. This is the proper anesthesia workstation. Okay, Boyle's apparatus is very basic machine. All right. Now, tell me which circuit is which one. I'm giving you 3 options: open circuit, semi-closed circuit, and closed circuit. Okay, so Zora is saying 3 is open circuit. Absolutely correct. Can you name this mask for me? Can you name this mask for me? Yes, very good. Not Kimmel Bush, Hemmel Bush. सबने नाम change कर दिया. Rita, Sita, Anita, all are different, but everyone is treating it as same. So this is Schimmel Bush mask. Schimmel Bush mask. Okay. All right. एक ही mask का नाम याद रखो सिर्फ Schimmel Bush mask. It is a famous mask. Schimmel Bush mask. Okay. All right. Then उस पे क्या करना है? You just have to keep ऐसे. That will be the mask, and on top of it you keep gauze pieces and you saturate the gauze pieces with chloroform. Okay, so then the patient will keep inhaling the chloroform and stay asleep. Okay, now what is 2? 2 is different types of Mapleson circuit. So that is Mapleson is semi-closed circuits. And what is 1? You can see fresh gas flow to the inspiratory limb to the patient, from the patient's lung expiratory limb to the back to the soda lime or absorber. Okay, and then back. So this is your circle system or closed circuit. Correct? All right. Now identify these 2 Mapleson circuits. Always asked in the exam. Mapleson में ना everyone is very scared of Mapleson circuit. They'll be like, madam A B C D E F क्या पूछेंगे? लेकिन दो ही Mapleson circuit are used in practical anesthesia. Okay, one is this and two is this. So you just need to know what is used in practical anesthesia because they will ask you only that. Okay, so देखो, one में you can see there is a tube within a tube. When there is a tube within a tube, okay, so that is your veins circuit. Vein circuit is what? Vein circuit is Mapleson D. Okay, and when you have two different tubes, you can see over here there are two different tubes. One is this oxygen tubing, dark green one, and one is that corrugated tubing. So this is what? This is your Jackson-Reef circuit. Okay, two different tubes. This is your Jackson-Reef circuit. All right, or JR circuit. What is this? Mapleson Reef में last में F आता है ना, so this is Mapleson F circuit. Okay, and this is used in children. Okay, this is the best circuit for children. You want to give spontaneous or controlled ventilation in children, then both of them you have to use Mapleson F. Okay, now another question that they ask about Mapleson, and you will be done with anything regarding your Mapleson circuit, is in Mapleson circuit, which is the best in when we are talking about adults, which is the best for spontaneous ventilation and which is the best for controlled ventilation. For spontaneous it is A and for controlled it is D. Okay, all right. So how will you remember this? You can always remember control. People who dominate like to control. Okay, people who dominate, D for dominate, like to control. So that is how you can remember your Mapleson circuit. Okay, and in pediatrics, spontaneous or controlled ventilation, whatever it is, you will prefer Mapleson F only. Okay, for all. Clear? All right. Next, ये बताओ फटाफट oxygen delivery devices. Now I have taken a complete revision of oxygen delivery devices before AIMS exam, and it came in INI CET also. So, but this is one flashcard which will help you identify all of them in just one picture. Yes. So over here, this auntie who is standing over here, she has something going into her nose. There is a big tube, and that big tube goes into this big box. Okay, so everything is big, big, big over here. So this is nothing but your high flow nasal cannula. FiO2 of high flow nasal cannula is 100%. What is number 2 over here? Number 2 over here that you guys can see is your simple nasal cannula. Okay, simple nasal cannula, or you can also call it as nasal prongs. What is the maximum FiO2 in this case? This you all must have seen in many patients in the hospital, 40%. What is number 3 over here? Number 3, this also you all must have seen in hospital patients. Yes, this is our normal Hudson mask. What is this chamber that is marked over here in Hudson mask? It's already masked as a nebulizer. So if you want to nebulize and give any drugs, you will fill it in that chamber. Okay, so this is your Hudson mask. FiO2, again, how much? About 60%, 50 to 60%. Okay, then what about this? If a bag is attached over here, I think this came in your exam also. Bag attached along with the mask. This is your non-rebreathing mask. FiO2, 100? No, 80%. Maximum FiO2, 80%. Okay. Now this one over here, big mask strapped tight onto the face and then connected to the ventilator over here. It's connected to the ventilator. What is this? Yes, this is your NIV. FiO2 of NIV, 100%. Okay. And over here, last one that you can see, helmet on top of the child. This is called as oxygen hood. Very good. Oxygen hood, FiO2 and oxygen hood, 100%. Okay. Yes. Okay. So these are our oxygen delivery devices. Identify test 1 in anesthesia and identify test 2 in anesthesia. Yes. Test 1 is Malampatti. Malampatti classification. You ask the patient to open his mouth and you will identify whether it is difficult airway or not. Okay. Test 2. And what is the maneuver required for test 2? Very good. This is Cormack-Lehan grading. Cormack-Lehan grading. This is after you see on laryngoscopy. Okay, once you do laryngoscopy, then what is your view? Are you seeing the entire length of the vocal cords, only the posterior part of the vocal cords, only the epiglottis and not the vocal cords, and nothing at all? So that is your Cormack-Lihan grading. Okay, and this is your Mallampati classification. What is Mallampati class 0? Here I have given you class 1, 2, 3, 4. What is Mallampati class 0? Yes, in Mallampati class 0, when the patient opens his mouth like this, okay, you can see right up to the epiglottis. You can even see the epiglottis. Alright? Okay, cool. Next one. Identify procedure 1. Identify procedure 2. And identify procedure 3. And also what are they used for? Yes, very good, Priyang and Shubhra. So procedure 1 is fiber optic intubation. In which condition do we use fiber optic intubation? Any idea? Fiber optic bronchoscopic guided intubation. But yeah, you can see you're putting this thing, okay, and it has a small flexible tubing which is going from the nose into the patient's nasal cavity, down into the oral cavity, and here up to the trachea. So this is done whenever you want to have an anticipated difficult airway, mouth opening is less, or patient has fractures in the maxilla and mandible. So in anticipated difficult airway, when you want to do an awake intubation, okay. And procedure number 2 is done in which case? Yes, you're putting a needle over here through the cricothyroid membrane. This is cricothyroidotomy. When do we do this? When do we do cricothyroidotomy? When the patient is desaturating. Okay, so this is an emergency airway access. Emergency airway access. If you cannot intubate, cannot put an LMA in the patient, we will do a cricothyroidotomy. Procedure number 3, you're putting pressure over here. What is this? Yes, this is your Selix maneuver. What it is also called as your cricoid pressure. And when is this done? Selix maneuver or cricoid pressure? Yes, this is done in rapid sequence induction. Correct? Rapid sequence induction or rapid sequence intubation. You do this to prevent aspiration of gastric contents. Correct? Alright. Next, identify position 1, position 2 and position 3, all used in anesthesia. And when do you use it? एक ऐसे बताओ, 1 is this, 2 is this, 3 is this. Okay. Position 1 is a ramp position. You can see you're creating a ramp. How do you create a ramp? You put bed sheets or pillows under the patient's head so that the tragus of the ear and the sternal notch all are in the same line. Okay. So ramp position, which is used in obese patients. Position number 2, you are placing a padding below the patient's shoulder so that this extension happens even more. What is that called as? Yes, it is called as rose position. Which condition do we use rose position in? Adenoidectomy, more than that, tonsillectomy. Okay, so your tonsils will be visible. The surgeon will sit over here and the tonsils will directly be visible. Tonsillectomy and also for intubation. Okay, sometimes for intubation also we use this rose position. Okay, what is this position? Number 3, lateral decubitus. It is also called as recovery position. Recovery position. When you're shifting the patient after anesthesia to the recovery room, you give them lateral position. Why? If they vomit, things don't go directly back into the trachea. Okay, it will come out to the lateral part of the mouth and outside. Okay, so this is your recovery position. Alright, positions batao. A क्या है? A is supine position. Patient is absolutely flat. B is head down. So this is when head is down, it is Trendelenburg. Okay. What is C? When head is up? When head is up, it is reverse Trendelenburg. Okay. What is D? Commonly used in gynac lithotomy position. Very good. What is E? E is lateral position, I agree, but which lateral? Right lateral or left lateral? They will give you both the options. Yes, which side is down? It depends on which side is down. Okay, so right lateral because the right side is down. Okay, what is F? Right lateral plus you can see over here there is a small break over here that is made in the table. table is broken like this, so that the kidney is pushed up. Okay, so this is your kidney position. Okay, what about G? What is G? Is the same again. It's same kidney position. What is H? H is prone position. Prone position may they love to ask, what is the most commonly injured part in the body in prone position? Eye, because your head is coming like this, so your eyes can get injured. Okay, and what is F? Fowler's position. Okay, it is also called as beach chair position. Yes, Fowler's position, beach chair position, sitting position. Okay, what is the most common complication in this position? Any idea? Very good. Air embolism. Okay, venous air embolism commonly happens in this. Eye injury commonly happens in prone position. Okay. All right. Next. Identify 1, 2, 3, 4, 5 types of laryngoscopes. Okay, very good, Zora. So you can see there is a lever attached, curved blade laryngoscope with lever attached. This is McCoy laryngoscope. Simple curved blade laryngoscope. What is this? Simple curved blade laryngoscope. This is our Macintosh, normal one that we use all the time. This is a straight blade laryngoscope. So what is this? This is Miller's laryngoscope. And what is option 4? Option 4, you can see a video of your airway. Okay, so this is a video laryngoscope. Very good. What do we use mostly in COVID? Any idea? What do we use mostly in COVID? Yes, in COVID, if they ask you, then you prefer to use a video laryngoscope. Why do we prefer to use a video laryngoscope in COVID? Because you don't have to look directly into the patient's airway. You put the laryngoscope here, and यहाँ पे TV होगा, so you look at the TV. So you're far away from the airway. Okay, so even if the patient coughs or bucks, his contents, aspiration contents will not come onto you. Okay, all right. Last type of airways. What is 1? What is 2? What is 3? And what is 4? Airway adjuncts. Okay, good. I'm seeing all different spelling of Giddle. Huh? Giddle, he will start moving in his grave, looking at all the spellings that you have given of Giddles. Okay, so 1 is your oropharyngeal airway. Absolutely correct. This is also called as Giddle's airway. Okay, now can you tell me Giddle's airway, what is the alternate use? If you don't want to use it like an airway to maintain the patency of the airway, then what can you also use it as? You can use it as a bite block. In patients who have epilepsy or are having seizures, you can use it as a bite block. Okay, all right. Number 2, you can see how it is going into the nose and it is opening up the airway. Yes, it is a nasopharyngeal airway. In which cases will you prefer nasopharyngeal airway as compared to oropharyngeal airway? Suppose they give you an example of a patient who has had trauma, in a patient with maxilla mandible fracture. Will you prefer to put a nasopharyngeal or oropharyngeal airway? Yes. So if you are not sure about how this joint is, how these bones are, or if the mouth opening is restricted, itna hi khul raha hai, okay, you can't hit the airway. There's no place to put the airway. So in that case, you will put a nasopharyngeal airway. In which case will you avoid putting a nasopharyngeal airway? Give me one example in which you will avoid putting a nasopharyngeal airway. Yes. So if you have any cribriform plate is fractured, and if there is any communication, skull base fractures, any communication with the cranial cavity, you will not use anything that will go into the nasopharyngeal airway. Second, any trauma to the septum, any trauma to the nose, you will not use. Any polyp, okay, any spur, nasal spur, you will not use nasopharyngeal airway. Okay. Okay, what is 3 and what is 4? 3 is bougie, correct? 3 is called as a bougie. Blue color का होगा तो याद रखो, it is bougie. Okay. So what will your bougie do? This is your vocal cords. So if you are not able to see it completely, first pass a bougie, and then on top of the bougie you pass the endotracheal tube. Okay. So this is your bougie. And what is 4? 4, you can put it inside the endotracheal tube and then turn the endotracheal tube. Make it a little angular shape like this. Turn the endotracheal tube. Yes, this is called as a steelet. Okay, steelet will be made up of steel. That is how you can remember. And bougie will be blue color. Okay, B for blue, bougie B for blue. Steelet will be steel shape. Okay, all right. So that's it with our 30 images for today. We've seen all the types of airways, all types of laryngoscopes, all positions, definitely more than 30 types of images. Then we've had procedures, tests, oxygen delivery devices, circuits, machine, defibrillators, endotracheal tubes, tracheostomy tubes, IV cannulas, regional anesthesia techniques, manometers, and this is a little bit about IVRA and brachial plexus block. Okay. Ashutosh, what do you want me to tell you about recovery position? Akan, which drugs do you want to know? Anesthesia drugs, is it? Okay, so Akhand, I'll tell you, this recovery position is basically the patient is made to lie down laterally. Now, why laterally? Because if the patient vomits under anesthesia, many patients vomit. Now, they're not completely awake and they're not in charge of their airway. So, if they vomit, everything will come to the lateral side of the mouth. If you're sleeping like this, whatever you vomit, it can go back into the airway. Okay. On the other hand, if you're sleeping like this, as per gravity, whatever comes in your mouth will get collected here. Then you can suction it out. So you're protecting your airway. Okay. Tomorrow's class, either from ENT or from because many of you all had asked ENT instruments. So I have prepared both ENT instruments as well as surgical specimens. So you know that specimen viva that you used to have in pathology or in surgery in 4th year, pathology 2nd year, ठीक है? तो वो सब specimen का, तो either one of them will be there for tomorrow. But we are going to be having this TMTI series every day. Make sure you're there on the Telegram group ACE NEET PG with Dr. Jhanvii, and I will be posting the class links over there every day at 8 p.m. Okay. All right. Kindly tell me more regarding endotracheal complications, intubation complications, and subcutaneous emphysema. Okay, while intubating the patient, endotracheal intubation, you can cause, first of all, damage to the tonsils, so it can start bleeding. You can damage the vocal cords, you can damage the arytenoids. Okay, so whatever comes in the way, you can damage all of that. Subcutaneous emphysema usually happens when you damage the trachea. Okay, so if this is the tracheal wall, and you damage a part of the trachea, then the air starts leaking out from this hole into the subcutaneous area. So you can feel it like crepitus. Okay. Neural blocks also supra infra axillary. They will not ask you so much in detail. You should just know what plexus you're blocking. So are you blocking brachial plexus? Are you blocking femoral nerve? Are you blocking sacral nerve? Okay. So if you guys want, I can put pictures of those different kind of blocks also. But you don't need to know so much in detail कि कौन सा interscalene approach है, कौन सा axillary, कौन सा supraclavicular. Okay. Alright. Okay. I will put it in the next session. Thank you, Subra, that you're liking the classes. Can you please tell about the first image? Oxygen delivery devices, I'll take it again on YouTube, so don't worry about that. Okay, and 10 o'clock every day we will be having a YouTube session also. Okay, so this is the first image, and this is nothing but IVRA, IV regional anesthesia or Bier's block. For those of you who came late, I'll just discuss this quickly again. So IVRA or Bier's block is basically used in patients in whom you want to just anesthetize one particular area. So you apply a tourniquet over here, as you can see, and you inflate the pressure. Now the question that they ask is how much is the pressure to which the tourniquet will be inflated. Okay, so the tourniquet will be inflated up to, in the upper limb, systolic BP plus 100 mm Hg, and in the lower limb systolic BP plus 200 mm Hg. Okay, and what are the drugs that you will avoid in case of IVRA is trilocin and benzocaine, because they both lead to methemoglobinemia, and the contraindications for IVRA are sickle cell anemia and PVD, peripheral vascular disease. IVRA means IV regional anesthesia. Neha, yes, I will show you the oxygen delivery devices. So we have HFNC, here, we have nasal prongs, then we have Hudson mask, then we have non-rebreathing mask, we have NIV mask, non-invasive ventilation mask, and we have the oxygen hood. Okay, summary of local anesthetic mechanism of action in one class and any recent local anesthetic. Okay, fine. Alright, so thank you, and I will see you tomorrow again, TMTI series at 8 p.m. Okay, alright. See you, bye bye. And if anyone is buying the class subscription, please use my code Dr.Jhanvi. Thank you, bye. And today at 10 p.m. guys, we have orthopedic X-rays discussion on YouTube, 10 p.m. Okay. It's free, it's live, it's available for all of you. The link I've posted in my group is NEET PG with Dr. Jhanvi. The brachial plexus block that I show will block the whole brachial plexus. It will basically block superior, middle and inferior trunks. Okay. All right. Bye.